I'm going to transition us to our next speaker, Dr. Tripuraneni from Kaiser. He'll be talking about strategies and tools to build access capacity and optimize health access within healthcare systems. And so I think you'll be quite intrigued by a number of the concepts that he's going to present. Dr. Tripuraneni, can I pass it over to you?
Yes, thank you. I'm waiting for my deck to show up on the screen. Okay. Well, thank you, David. I am delighted to be part of the presentation today, and I would like to thank National Academy of Sciences and also the Veteran Healthcare System to putting together such an important conference and workshop for the audience. What I would like to do is I would like to spend the next 15 minutes to talk about the strategies and tools going into really the nuts and bolts of how to improve access. I'm a practicing child and adolescent psychiatrist, and I work at the Mid-Atlantic Kaiser Permanente, which is part of the Mid-Atlantic Kaiser, with 1,650 physicians. So our system of care is almost similar to VA. It is an internalized, integrated care system because we are a HMO. So the going into the operational access improvement concept, it is really it really embodies 3 different components, and it requires constant visual because we have to make sure these fundamental concepts are followed at every step of the access improvement strategies. The leadership has to be committed at every step of the way to make sure the access journey is moving along in the right pathway. And you have to make sure there is an adequate supply of the appointments, at the same time not wasting the valuable and expensive resources and optimizing the supply. And of course, no matter how much planning you do, and if you're not going to have an execution at the right time, nothing will come into fruition. So I'm sure you all know that the key pillars of the access are demand and supply. These are the 2 core principles that we will get into a lot more detail. And whenever you have an imbalance between the demand and supply, what happens? You're going to have a backlog. And once the backlog becomes huge, and it is going to result in delayed care, and the delayed care leads to increased morbidity and, of course, huge member dissatisfaction. This probably is the most important slide that I will be presenting in the entire deck. This is the flywheel. You can consider the access cycle as a tri-legged stool. So you need to maintain these 3 legs in a stabilizing fashion. I would say unless you have all these 3 interconnected features, you cannot maintain adequate access. Every component of the presentation that I will be doing for the next 10-15 minutes will be what we went through in the Mid-Atlantic Kaiser Permanente in improving our access during the last decade. So let's look at each of these 3 components. The long-term supply and demand planning. You must have data on demand forecasting by using historical demand adjusted to your patient population that you will be serving. Based on this, you need to plan your clinic resources to meet the demand. When I meant clinic resources, I am referring to the number of the physicians working and their schedule profiles, and making sure there is the right appointment type mix, which we will get into. The next component of the cycle is going to be monitoring the balance of appointment supply. Making adjustments to seasonality and also the core staffing, because you are going to expect some lost resources because we live in real world, because of the vacations or FMLAs or unexpected sicknesses of the physicians in the department. All of those are going to have huge impact in your appointment supply. And then the third component of this access cycle is going to be the retrospective evaluation of performance. So you have to immediately look back, not months later, not quarters later. You have to really look back literally within weeks or within days of what happened in terms of your supply planning. What was your access performance and the accuracy of what you forecasted earlier, so that it will lead you back to what you need to go back to forecasting for the future. Once you have worked on all the three components, this access cycle, you will be very pleasantly surprised. This actually works very well, these three components. And when you provide access very well, it works for physicians and it works for the staff. And most importantly, the patients too. Patients will be happier because you are providing terrific access. Then let's look at the supply and let's dig in detail into supply. The supply is, of course, one of the most important and critical lever that you have to focus upon in maintaining adequate access. This slide illustrates the levers you have for the supply. The key levers are what percentage of the physician's schedule is what we consider as a bookable clinic schedule. As an example, in an 8-hour schedule, we typically book between 7 to 7.5 hours of time as bookable schedule, and the rest of the time is earmarked for desktop medicine or finishing the charting and etc. And also you needed to look at the overall bookable time you have in each department by each location, combining for all the physicians who are working on that particular day. So you have to maintain some sort of a master calendar. And also in some of the surgical specialties, you would be able to use physician extenders to be able to leverage physicians' time so that you can increase your access capacity. So when you combine all of these components of the bookable time, then you will be able to move on to what's happening to exactly the individual provider schedule. In individual provider schedule, you do need to focus on the length of the appointment and also what are the ratios between the appointment consults versus follow-ups. By the way, the focus of my presentation is primarily related to the specialties because I wanted to concentrate the nuts and bolts of the specialties. And the key components of the strategy also as a part of the access planning is in terms of your staffing of not only in the short term and the medium term and the long term. And of course, the short term is going to be you have to make adjustments on a weekly basis, on a weekly, daily basis to make sure you have adequate number of physicians who are working in each location. On the medium term, you have to build your schedule of the physicians and the plan for vacations well in advance and making sure you are covering different venues if you have physicians rotating in different locations. And of course, the long-term planning requires that you have appropriate number of FTEs so that you can manage the access appropriately. And in managing supply, you have to look at all these different components of metrics, and these metrics needed to be validated with the specific data. I think the data, of course, is going to be a very key component. One area of the supply that I wanted to make sure that I want to address is there are other ways of managing the supply of your specialty care by providing alternative avenues of providing specialty care. One of the key components of what we do within our organization in the Mid-Atlantic Kaiser Permanente would be chart review. We use an Epic software. The Epic software allows our primary care physicians to be able to send a chart review note, which is basically a curbside consult, what to do to a respective specialty. So it goes into an in-basket of the respective specialty department. They have a schedule who will review the in-basket, and the expectation would be to respond within 4 hours to a response to that request made by the primary care physician. And by doing that, what you are able to do is you would be avoiding unnecessary specialty consults so that you can decrease your demand, so that you are at the same time giving advice to your primary care physicians so that they can manage the patient appropriately. And at some point, if in case they do need you to refer the patient to specialty physician, they can send the patients to specialty care. And also we use extensively phone consults wherein a primary care physician can contact a specialty doctor in one of our specialties like gastroenterology, we call as a gut phone. A primary care physician, while the patient was in the exam room, can call a gastroenterologist who is carrying a spectrophone all the time during the day with a limited patient schedule so that he or she can answer the phone and respond, and if necessary, even ask a question to the patient. What it does is it eliminates unnecessary trips for the patient and avoid a specialty consult. And of course, the telederm is one of the key component of our strategy extensively. And we also have been using other digital image secure messaging from the patients. In fact, Leonie earlier talked about the patients taking short videos following a knee replacement to record their range of motion and send it to an orthopedic doctor or to a physical therapist. So we also extensively encourage and use our patients to send pictures. For example, post-op. Do all post-op patients need to come back to see a physician? Probably not. So now we are living in the world of smartphones with high quality picture capability. So we have been extensively using those tools also. And then I wanted to spend some time on vacations. You might wonder why. You may be surprised. This is one of the major issues that we always deal with. And this has a huge impact on the ability of patients, our ability in a system to provide adequate supply of appointments. So you got to make sure you have a vacation policy, and you got to make sure you have core minimum staffing requirements. And also you need to have exactly plans to what to do if more physicians request vacation than is allowed, because everyone would like to have vacation during spring break and everyone would like to have vacations during Christmas break. And then I would like to touch base on two different types of templates. As an example, if you look at on the right side, it is considered, the right side with the blue circle, you have a standard template of a specialty physician with 5 consults, 3 follow-ups, and 1 procedural consult. In a 225-minute time of a 4-hour block, let's assume the rest of the 15 minutes is charting time. We use what's called a standard plus, an alternative template, which is kind of in the back end. When you have a physician going on vacation, especially on a short-term vacation, you are going to have a huge net loss of appointment supply. So we pre-plan and activate this schedule for the existing physician so that you are mitigating the loss of the supply in a very short timeline. And then also we do actually measure our net loss of our physicians' productive time. The net loss is basically what is the loss of the productivity of the scheduled appointments, basically combining the patient no-shows and unused appointments because you have last-minute cancellations or totally unused blocks, and giving the credit to worked-in appointments, dividing by the denominator of the appointment supply. And you may be surprised once you start pulling this data, you will realize there is a huge variability between physicians to physician and a clinic to clinic. Our goal is to try to optimize and keep the net loss well below 10 to 15%. And then we also have used another technique in terms of using 2 different types of appointment templates. One on the left side is a variable appointment template in a specialty, wherein you have a consult with a duration, longer duration of 1 hour. Let's assume it's an oncology or infectious diseases because they would require longer appointment lengths, and a follow-up appointment, which can be a half an hour appointment in that specialty. It has its advantages, but the disadvantages being you are caging certain appointment type at a certain time, and then it will lead to higher net loss of the point, and it minimizes the patient's flexibility to choose the appointment that they would like. We are moving now pretty much to almost all of the departments, what we call hybrid or flexible appointment types on the right side that you will see, wherein we standardized all appointments depending upon the specialty, whether it's a 15-minute or a 30-minute or a 40-minute, so that it will, what we call as a flexible appointment that allows booking patients into any of the appointments. And then we have found out this definitely leads to a lower net loss. Since I did get a reminder for only a few more minutes that I have, I'd like to wrap up in a couple of minutes. And you also do want to manage your demand. And when you are managing the demand that is coming the primary care, which is really a key component, you have to take proactive steps. You have to invest time that will pay off in the long run by communicating and educating the referring providers. Unless that is done constantly and repeatedly, you would not be able to manage your demand, or what we consider as a utilization. And I'm going to skip the backlog and front log. And then I would like just point out and highlight the importance of data. Establishing a measurable goal that is aspirational and achievable is really important to drive the performance. Along with setting up the goal, you have to have the data to support and validate that performance with the data. This should allow you to take necessary steps to make sure that you are achieving the goal. So ultimately, to sum up, you want to make sure you translate your strategy into action, for which you need leadership engagement constantly, and you have to expect consistency in performance across the board with all the physicians that you are working with, and also reduce the variability in performance, which is a key. And you have to make every effort to minimize the idle time, because any idle time is a wasted precious resource. And you have to constantly look at technology-enabled alternatives to doctor office visits, whether it's a video visit or digital images. And then you have to foster a culture of teamwork and innovation that is coming up from the ground. And finally, you have to monitor the performance, of course, and you have to share the data, performance data, and it has to be shared that is unblinded, so that every physician within the same department can see the performance of their colleagues. It should never be blinded, because if you do blind it, you are not going to see an improvement in the performance. And then to finalize, concepts of the access improvements are very simple. Everybody knows them. What I have shared here is nothing new or nothing, it's not a rocket science, but barriers tend to be very internal almost always. Implementation during initial phases can be very complex and rocky, but it does get easier. But once you see the results, and the outcomes are going to be very rewarding and very long lasting. So for a sustained access improvement, you have to really focus on the long term, because access is a journey that never ends. And then I will end with this quote from Charles Darwin. Thank you.
Thank you very much. That was a fascinating conversation, and one that was very practical, and yet touched on all the major points that I think have come out of the workshops thus far around kind of achieving outcomes across a spectrum of stakeholders, including patients, systems, as well as the providers. And how do you actually balance a lot of the competing demands that go into high quality care and access. So thank you very much.